Hello, everybody. I'm a pediatrician here in Moscow. I'm currently the only provider who prescribes a lot of medications to children and adolescents within about 90 minutes and with less than a 12-month wait list. So I've taken a lot of extra learning after peds residency to try and be able to assess and treat kids with mental health disorders in our area. And so I have a big long deck of slides that I'll just go basically until Michelle tells me I'm out of time, and then the rest will just be for your own review or learning. I started with the ones that I most commonly use, like on a daily basis, probably, ending with the ones I don't use quite as much. And if you're out there in the behavioral health community, I guess my hope and goal would be that I have found when I moved here, most of the family practice doctors I worked with weren't aware of all of these resources and screenings. And so I've just been trying to spread that word. So I guess that'd be the goal, do the same. So next. So the main objectives is I'm going to present some validated screening tools for the most common childhood mental health disorders that I use in the primary outpatient pediatric setting, with resource links. And then what this is not is a presentation about diagnosis or treatment. That requires much more work. I'm going to go over starting at the beginning with general screenings through some of the more common things I see and screen for. I kind of put at the end stuff that probably has its own echo and behavioral health topics like trauma, substance use, eating disorders, autism are kind of super big areas. So if I don't get to the screenings I use for those, they're probably presented in other places, but they're in this resource guide. One of the most useful things I've started doing in my practice is just general screening questionnaires that all well child checks. And then anytime somebody presents with a behavioral health concern for their child or adolescent, I kind of do a quick intake and then give them a packet and say, fill this out. As long as you're not in crisis, come back in a couple weeks for a longer visit and we'll review all these things to see what type of things we're looking at. So the PSC, or Pediatric Symptom Checklist, is one that assesses for a number of areas of child mental health disorder, including like ADHD, anxiety, mood disorders, and then a number of externalizing disorders. And it's only in the last couple of years, even after pediatric residency, that I started learning more about these kind of domains of child mental health disorders, the attention, internalizing, and externalizing. And so a lot of the validated behavioral health screenings differentiate into those categories. And so my reference here is number one. It's the first reference in the slide. And I'm sure a lot of you are aware of the Seattle Children's Pediatric Mental Health Guide. So a lot of the questionnaires are available for free reproduction in that guide. And so I have the link to it at the end of my slides, but also if you just Google PALS Guide, Seattle Children's, it's like a 106 page guideline for multiple mental health disorders in children that you can use. Go ahead, next slide. And this is what the PSC 17 looks like. It probably takes, 5 minutes for parents to do. It actually, for some reason, takes me a long time to score. I'm not very fast. So I have them fill it out and then you score the areas. And then one of the really nice things about this guide is that right on it, it tells you what scores are considered positive screens. And then, so for example, the way I use this is if somebody scores kind of positive for the attention area, I look more into ADHD. If somebody scores positive for like same thing for internalizing versus externalizing, I'll kind of go in the direction of those disorders for further screening. Next slide. The other screen I commonly use, and this is used a little bit more in our some of the local clinics that they do, is the DSM-5 self-rated cross-cutting symptom measure. It's nice because unlike that PSC that I just showed, there's an area, it just shows more domains in areas of concern, and it's less of like a positive screen and more just like, hey, a little star, you should look in this area. And it's also available for free and you can use it. And this is the link. Go ahead to the next slide and we'll look at it. And this is just what it looks like. You'll see that you just have parents score in different areas, and it's typical things that are positive scores are depending on each domain. So then go ahead into the next slide. sorry, the next one. Those are just what the screening looks like. So this is how you actually score it. It's different. You're not like adding up a bunch of points. So for each thing, like domain 1, somatic symptoms, if they report mild or greater, it's considered a positive screen. So I probably use this the most in anxiety and substance use and inattention and depression, whereas a lot of the other areas I'm just getting based on like report from parents. So if you go ahead and go back, because it took me a while to learn how to use this well, because each colored box is a domain. So like domain 1 is number 1 and 2. And if they're scoring like mild to moderate is when it flags me that they're probably having some somatic symptoms that I should address. So you can go ahead to the next screening questionnaire. And then I think this is the final one I typically use. It's very nice that they call it strengths and difficulties rather than like positives and negatives. So we're trying to, it helps you identify some strengths that children have too, especially when you're addressing a number of like mental health disorders. And you end up getting 5 scales in these different areas. And it's another nice thing about it is it has many different ages. So age 2 to 4, age 4 to 6, age 6 to 8. It's the only general screening for mental health disorders that I typically use in young children. So go ahead into the next slide. And oh yeah, that was the link to it. I didn't end up putting those in here because there's so many different ones. I think I handed that out to like 3 parents yesterday when they came in with kids' behavioral health concerns, as I'm seeing a lot of during remote schooling. So it helps because they can, I don't think any other of my guidelines I have access to are for young children. So, and I sort of already said this, my general purpose with general screenings for children is that I use some in every single well child visit, but in general, it's the parent who says, I'm worried about this. And they say that usually at the end of their like well child visit or at the end of their like pneumonia visit. Like, well, let me make sure you're not in crisis. And then let me give you this packet to fill out. Why don't we make another appointment and come back? And I found that to be like the most useful for general screenings. I think I've even started doing some of them in the inpatient setting because we definitely have seen an uptake in kids in behavioral health crisis getting admitted to our local hospital. And so a lot of those kids have never presented to their primary care doctor for behavioral health concerns. We don't have any access to psychiatry or even a local therapist who consults in the hospital. So it's just sort of me taking things in and seeing where we're at as far as like, is this an immediate crisis or something bigger? So I found those general health screenings to be even helpful for parents to complete when their kids are in the hospital waiting for something. So go ahead and go to the next slide. I'm sure a lot of you are aware of these. These are ones that we don't have access to because they're fee for purchase, and our psychologists will do them as part of like greater neurodevelopmental screening. So it's just good to know that they're out there and they're much more comprehensive and they cost money. So that's why I don't do them. The most common screening I use in anxiety. Again, I learned this one in residency and then some more through like CMEs. But I'd say I work in a clinical practice of 13 family practice doctors and none of them had ever heard of this before, but it's the one they were all using like the GAD and 4-year-olds. So I use this for children. It's nice because there's a child version and a parent version, and it's validated in ages 8 to 17, although I'll have like a very mature 6-year-old complete the child version sometimes. It takes like 10 to 15 minutes to complete. So it's, again, almost always I have to give it to them and say, go home and bring this back at our next appointment. And it's nice because instead of just identifying like, hey, I'm worried about anxiety in this person, it scores in different areas that tell you about general anxiety, social anxiety, separation. Are they having panic or somatic complaints? And then is anxiety presenting as like school avoidance? So go ahead to the next slide. Here's what it looks like. So there's one for a child and one for a parent. And they just answer in these categories and you end up scoring it in different areas. So go ahead, next slide. And this just describes the scoring. Again, this is from that PALS guide through Seattle Children's. And so it's very nice in that I have lots of copies of these in my office. And so the scoring, my nurses typically will help me with. And then it seems to really help in getting kids in with counseling, as well as counseling their parents about what areas of anxiety seem to be coming out the most, and because there are different ways to address that. Go ahead to the next slide. And I mentioned the GAD or generalized anxiety disorder scale. I will use that because a lot of the questions on the scared, even though it's validated to 17, my teens find kind of silly. So it's like asking about if they like to, if they're like get anxious if they're or nervous when they are separated from their parents. And so there's a lot of like younger type of questions on the scared, even though it's validated to 17. So I probably do the GAD in older teens and adolescents as well. And it's helpful for initial screening and diagnosis. Next slide. You all know what it looks like. I'm sure almost everyone has seen this and done this. I find it really helpful to walk through. It's such a like easy, simple test. I'll go through like each item with teens and talk about like the first two especially. And then one thing I really like about the GAD is it talks about the trouble relaxing and worrying and being restless. And they're always like, oh yeah, it makes sense that my anxiety makes all those things happen to me. So I find GAD still useful for kids. Definitely the most common or second most common diagnosis and thing I'm seeing in outpatient pediatrics is ADHD, especially now that parents are teaching their children. So I've seen a lot of like requests for new diagnosis for that. So the Vanderbilt's probably the one I most commonly use. The important thing about it, I think probably almost everyone on this call has heard of it or seen it. It's pretty, it has pretty good validity in screening for ADHD and then even taking your clinical judgment, diagnosing it with the Vanderbilt's. The biggest problem is with age. So it's useful for younger ages and I think it becomes less sensitive and specific the older you get. It's definitely not validated above age 12. So if you get a lot of like high school kids or teens coming in, they need a lot more formal testing. There's a parent and a teacher version, and the main downside, there's no child version. So that's another reason it's not as helpful with teenagers or older kids because they aren't allowed to self-report their symptoms through a Vanderbilt. I use it most at when I'm screening kids and looking for diagnosis, but then you can also use them in follow-up to see if they're improving with medicines or your other interventions. Go ahead to the next slide. This is what it looks like. Some people who are actually seeking a diagnosis that don't have ADHD will like know how to answer it to get the diagnosis. So because the scoring is pretty much out there, go ahead to the next page. This is what the back of the teacher rating scale looks like. The most important reason I brought this into this slide deck today is I've seen people use the Vanderbilt diagnose ADHD off it when they have the positive scores, but they don't actually have the scoring required for performance for the latter half of this, which you see performance problematic. It requires problematic academic and classroom behavior in order to have a positive screen on the Vanderbilt. Go to the next slide. This describes the scoring and why I brought it up again. So you can look at inattentive and hyperactive types, or combined. It requires for the initial screen positive 6 or more CATA behaviors on items 1 through 9 and a performance problem to be considered a positive screen. The Vanderbilt scoring can also bring up positive screens for like conduct disorder or oppositional defiant disorder or anxiety depression, but I have another slide about that. Go ahead forward. So like I said, the younger age groups, the Vanderbilts are more reliable in if you're going to screen in positive and then go on to diagnose them. But for older kids or when there's a question, I almost always have to send kiddos to our local psychologist to do Connors testing or other types of ADHD comprehensive testing that have varying levels of availability. And these are the two probably most common I see come out. And then, sorry, I have to sign something. There you go. And so, yeah, just so it's good to know they're aware of that and like the most common ways to screen in ADHD. So go ahead to the next slide. I'm putting a slide in here about conduct and oppositional defiant disorder because I have never diagnosed these and there's emerging evidence of racial biases in these diagnoses. So I just included a link to this review article that highlights when compared to non-Hispanic white youth, some ethnic and racial minority youth are more likely to receive a diagnosis of these disruptive behavior disorders and less likely to receive a diagnosis of ADHD. So I've just taken I'm not a psychiatrist, I'm a very cautious approach. Until we know more about our own like implicit biases and the history of these diagnoses, I don't diagnose them. And I've actually been able to, because they have such high comorbidities, often they get a different diagnosis and we're able to help them anyways through therapy and medications and school-based plans. So I put a slide in it because I don't talk about it as far as like screening or diagnoses. So moving on to depression, I screen everyone at adolescent and well visits for with a PHQ-2, and this is all teen and adolescents, and this is on the recommendation of the American Academy of Pediatrics. If they get a score of 3 or greater, then I give them the PHQ-9, which is helpful because it's validated in teens and adults. So a lot of our like adult providers who see kids sporadically can still do a nice job screening kids for depression. Go ahead and next. Probably everyone has seen what the PHQ-2 looks like. So that was just part of our like well child adolescent teen check-ins. And then go ahead to the next slide. And PHQ-9, I think everybody has probably on this call has probably seen the PHQ-9 and how to score it. I always like look immediately to the bottom box because I think that helps me like flag in how my visit's gonna go. If they're answering that they're having thoughts of hurting themselves or they'd be better off dead, I know I'm going to have a little bit of a longer visit and needing a really close follow-up. So I highlighted that. Go to the next slide. As I said, the PHQ-9 is not validated in prepubertal children. And so that's where a lot of those earlier screenings for me, the general screenings I already went over, come in, as those can kind of screen positive for depression and prompt further investigations. Go ahead to the next slide. This one is used in younger children, so I'll use this one as well. Sometimes when the general screenings or the parents are concerned about depression in a younger, like 6, 8, 9-year-old, and I'll give this as well. It's not quite as sensitive at picking it up, but that's probably okay because you're already just doing it to see if they are more likely to have a depression. The nice thing is there is a parent and child version even for the younger ages. And it probably only in the last year did I discover this screening tool, which is why I wanted to include it. And it's also available in the PALS Washington guide. I think that wasn't when I was in residency, they didn't have it in there. That's why I didn't know about it. And now I've been using this a lot more. So that is the next slide. So this talks about how you score it. The important thing about this is the child version is a little bit more useful at screening in, and like the parent version has not been has not performed as well in the literature for validation. So that this is especially helpful for me when a parent comes in and says my kid seems sad or depressed, and then I get a positive screen on this. Go ahead to the next slide. I have a slide about bipolar disorder. It's not something I diagnose in kids. I'm not a psychiatrist. But I know I typically will suspect it when I see episodic mood changes with manic features. The diagnosis in general has become more controversial in the last decade, especially in kids before age 10. If I'm thinking about it, I usually am considering other diagnoses first, and then if I'm still thinking about it, would move more aggressively to get a kid with a psychiatrist. So go to the next slide. This is again from that Seattle Children's PALS guide, and Seattle Children's is on a team of emphasizing that they think bipolar disorder is more rare in general in children. And so this highlights that if the children screen in like with more traditional bipolar symptoms like mania or psychosis or severe suicidality, that's when you would consider bipolar 1 or 2 and get them in pretty quickly for evaluation. If it's more vague and they're just kind of having these kind of episodic patterns, and we wonder more about like bipolar spectrum, which is still in the area of controversial diagnosis and lots of comorbid overlap. So I've found this algorithm helpful as an outpatient clinician in deciding where to go to pursue, could this child have bipolar disorder? Next slide. And there are no readily available validated screenings in children for bipolar disorder. So it's really just like a clinician's kind of heightened awareness and concern, and then pursuing further evaluation. I have given the mood disorder questionnaire to adolescents and teens when I'm more concerned about bipolar disorder. And if you haven't seen that, go ahead, next slide. This is what it looks like. It hasn't, if they have a score of yes to 7 or more of the 13 items and they answer yes to question 2, then they have a moderate or serious answer to question 3, then I think, this could be bipolar disorder, and I again try and get them in with someone. And this diagnosis, if you haven't heard of it before, disruptive mood dysregulation disorder, it was just kind of emerging at the end of my training since the 2010s. And kind of in response to the high rates of bipolar disorder that were getting diagnosed in young children in the 90s to early 2000s, especially on the East Coast. So the diagnosis actually requires, it is now part of the diagnostic and manual. It's persistent and pervasive irritability underlying and punctuated by frequent temper outbursts. And it has to be greater than 3 times a week, at least 2 settings, greater than 12 months. Again, this diagnosis is still kind of controversial in the greater psychiatric community. I see lots of strong evidence for it. The reason it has been called into question still is there are very high rates of comorbidity, including diagnoses as ODD, conduct disorder, ADHD, et cetera. However, that also still is in question because of our questioning conduct and ODD as well. So I've found probably more and more kids getting diagnosed with this, but some of the benefit being we're learning more about medicine combinations and comorbidities that may be useful in treating it. So go ahead to the next slide. Oh yeah, I guess I only have one slide on that. So my biggest thing is there's still lots of providers and clinicians who aren't aware of that diagnosis. And so it's something to consider and look at when you're seeing that pattern of behavior. And I've seen lots of psychologists in our area are starting to evaluate and give that diagnosis. Oh, look, I had enough time to get to autism. Pretty good. So autism is definitely something I screen for and evaluate a lot, and learning more about kind of more advanced screenings than just the MCHAT, which is probably the most commonly known in the outpatient setting. It's nice because it's quick. It takes like 5 minutes and it's pretty easy to score, and it's validated for children 16 to 30 months, both pretty high sensitivity and specificity. Go to the next slide. It used to be copyrighted and you had to pay, but now it's free. And so I always have to look this up, even though I do this on like all 18-month-olds and anyone else with concern. Is the scoring is a little confusing. So you have to, for all items like that are 2, 5, and other than 2, 5, and 12, the response no indicates ASD risk, whereas those questions, the response yes indicates ASD risk. And then describes how to score it. Most of my colleagues here weren't necessarily aware what to do when you get a positive screen. So the low risk, you're like, yay, nothing. The medium risk, the recommendation is to do a big long follow-up screen. And then the high risk, often you're like, if you're very concerned about autism, I'll just straight refer them to our area for autism evaluation. We're actually pretty lucky. We have a University of Idaho person who does autism evaluations and gets kids in, well, before COVID, would get kids in for evaluation for autism within 3 months, especially if they were school aged. She would move really quickly. And then, so I had just so everyone's aware, like I hadn't been aware of the MCHAT follow-up. Then they take every single one of these questions and they take parents through this big, long algorithm flow chart. It's a pretty long, it takes 30 plus minutes to do. And then for me as a clinician, it takes me that long to review. So if I get these kids in the medium risk and I'm not referring for formal autism eval, I'll make like a 30-minute appointment to do this with the parents. The other thing that is useful, and I like this one because it's useful for the older kids, because again, the MCHAT's only validated till age 2.5, is this Childhood Autism Spectrum Test, or CAST. It's available again for free. It has really high sensitivity and specificity. So if you screen positive for it, I'm going to have a pretty high concern about autism diagnosis. This is what it looks like, but I'm not going to go over how to score it because I put it on my slide. It's pretty easy. And then the final one, the final one for autism that I'll use is the POSI. and people in different states use this. So some people may have heard of it, some others not. It's again, only really valid for the same ages as the MCHAT. It has increased sensitivity, so it picks up more kids with autism, but the MCHAT's actually more specific. And the nice thing about it though is it's faster, it's quick. Go ahead to the next slide, and this is what the POSI looks like. And then go ahead and click the next slide. This is how it's scored. So you get 7 questions, you only get a point per row. If anything is checked 3 or in the final 3 boxes, you don't get like multiple points for the given row. So the maximum score is 7. If anything is above 3 or 3 or above, then it recommends referral for autism evaluation, which is why it's so sensitive. It's like, yes, refer everybody. Oh, I forgot. So I do get a lot of like teens and college kids who come in, or their parents bring them in, and are concerned about autism. And to be honest, sometimes I'm not sure if that's just video game induced, I don't know how to say it, social isolation, because I've seen a ton of that right now. Kids not leaving their rooms and not speaking to anyone, and even some sleep disturbed and like video game induced psychosis. But I have had to like dig for how to even question if kids could have autism after like the teenager college years. So I have used this AQ10, and so maybe some of you have heard of that, but it allows basically for more of like a late diagnosis of probably what was more mild autism versus not. Next slide. That's what it looks like. It's really easy to score, and it's all described on their website. Am I out of time, or should I keep going? Okay, cool. So another thing that comes up with autism is I'm always worried about it if I'm seeing developmental delays in areas, especially speech or communication, and social interactions being like the most common. And so anytime I have a question of a delay, I'll give the ages and stages questionnaire. This one is copyrighted. It's a fee for use. You can actually access it and give it verbally without being charged, or there's like, it's actually a pretty small fee for a whole clinic like ours. So we give it out. I give it, the recommendation by the American Academy of Pediatrics is at least 9 and 18 months olds get it, and then I'll give it whenever there's a concern. It tests for areas of developmental delay in 5 main areas, and it's available up to 5 years of age. And so when you have a young child, especially before the age of 5, when a parent is concerned about a potential behavioral health disorder or just worried about their behavior, I'll usually give an ASQ in addition to some of those other general screenings I mentioned. Go ahead and go to the next slide. It's nice. It's really parent and user friendly. It's available in, I think now, like 9 languages. And this is just one page, what the communication section looks like. And they have to answer like, does your child do this? Yes, sometimes, or not yet. Go to the next slide. And it scores. If they say not yet, they get a 0. If they say sometimes, they get 5 points. And if they say yes, they get 10 points. And so then you score up each section based on that. And then this nice guide that's as part of the ASQ tells you when you need to be worried or do further work. So if they score up in the white boxes, everything's fine. If it's in the gray, it recommends you follow it. And if it's in the black and in the area, that suggests they need further evaluation with professionals. Next slide. So again, AP recommends it at these times. And then I'll do it anytime a parent has concern about behavior or development. And for example, I'm worried about their speech. So maybe I'll just do the communication section because I don't have time in my clinic to run through that very long. It's about 30 minutes probably if I was going to walk a parent through the whole thing. And then if they immediately score into that black area in communication, I'm going to get them in with probably like the infant toddler program or a speech therapist at our local hospital. But then it also kind of flags for me to screen for autism again as well, because I see that often with communication disorders. Next slide. This is another developmental screening I just wanted people to know about and be aware of. It's also available in that Seattle Children's PALS guide. It screens more for emotion and behavior concerns than developmental concerns. So it's useful as just like another addition to evaluating a child. Next slide. It looks like this. It's long. I usually do this one as part of a more like longer evaluation with a kid. Next slide. And then I made it to the eating disorder. I've worked in Moscow for 3 years. And then in the last week, I've had 2, it was the first time ever I've had 2 young women have such bad anorexia. They had to be hospitalized and are now going to be placed in like residential treatment. So I don't know what's going on, but that's going on. So I haven't traditionally been screening for eating disorders on a general basis, but I guess I should start. So this is my motivation. So this is they're probably the main validated screening disorder for eating disorders. It's called the Eating Attitudes Test. It's kind of annoying to me that it's called EAT. I don't really like that, but that's what it is. I'm going to the next slide. This is what it looks like, and then the next slide describes scoring. Again, it can't take the place of a diagnosis. It just gives us when we should be concerned. So a score of greater than 20 when you add it all up is more high risk for an eating disorder. Go to the next slide. My final discussion would be on trauma, which I know ECHO has I think it has a whole session on. And so I tend to use screenings for trauma when I'm doing other behavioral health disorder screenings, but I don't use it on every patient. In general, the take home is like, as I was taught in residency, as well as has become apparent, is do inquire about trauma for in children. But I avoid asking specific details as I'm not highly trained in that. I use specific questionnaires, and then if there's more concern, I pretty quickly get them in with counseling. And so the main ones we use, go ahead to the next slide, I like everyone to be aware of is it's related to the scare, but it's specifically screening about traumatic or PTSD. It's really easy and quick to do. And so if I have concerns about trauma when I'm evaluating for anxiety, I'll add this to the screening questionnaire. And next slide. I think everyone's aware of ACEs and ACE score, but a really great resource in children, teens, and adolescents is the Center for Youth and Wellness. Their ACEs questionnaires that were developed by Nadine Burke-Harris. They have child versions, teen versions, and teen parent caregiver versions. So the teens can self-report, and the language in the child version is probably way less trauma-inducing than if you gave them an actual ACEs score. So it uses different language and wording that is developmentally appropriate. It's free for use. You just have to like log into this website, give your email to sign up, and then you have like a free access to this big, beautiful guide about how to give ACEs and incorporate it into your clinic or whatever setting you are in. So I found that I started doing that in the last couple of years as well. And it's been eye-opening to learn about how many of my patients screen positive for trauma and how it's really important to get it incorporated into their treatment plan. There, I think I made it. So really useful is this link to, if you have never seen the Seattle Children's Primary Care Principles Guide, it's really useful.
Incredible. That was fantastic. A drinking from the fire hose of all the great things. I want to let Dr. Whitaker ask any questions or follow-up thoughts before she has to leave.
Hi, Summer. Thank you. That was so hi. How are you? That was awesome. Thank you so much. Yeah, I think one of my questions for you is just in terms of, and I'm sure this is a little more complicated, so maybe we could email about it, but I'm curious about which ones. We're kind of working on our pediatric packets and what we give to everybody. And we have some of those guidelines from the AAP. So I don't know if you followed those guidelines, because I know the PHQ comes up on there. Haven't looked at it in a little while, but in terms of if it's just a kid walking in off the street, how do you decide how much you screen them for, or which ones? Do you guys have packets you give them at Well Child Checks, and are there guidelines you follow on that?
Yeah, and I do. I mean, probably the early child checks before the age of like 5 to 6, we just do ASQ and autism screen. I don't always screen everyone, except for I'll just ask parents, like, do you have concerns about behavior or development? So probably end up like giving packets to like 30% of Well Childs, but I don't give them to everyone. Okay. Because if I do give a packet, I want them to return it, and then I'm the only one here who's a pediatrician, and I'm the only one who scores it. So it's like too much labor for me. But certainly like clinics that are more equipped could do a nice job of giving them to everybody. There's no reason not to if you have the resource. And then the older kids, I do the basically adolescents and teens, I'll give a PSC 17.
Okay.
and then PHQ-9.
Okay.
Or the PHQ-2, and then follow up PHQ-9 to all adolescent teen visits.
Okay.
And if any of those are positive, then I give them like the whole packet of like all the things.
Okay. Perfect. And with those packets, do you have them spread out by age, like what you would give if at
I
this
do.
age, if you had a concern about mental health, this is like the packet you give them?
Yeah, I have a nice little file folder, and I just go and like pull from it.
Yeah. Okay.
It says
Cool.
2 doctor day on the top, and they have to like return it. It'd be really cool if it was electronic, but
Yeah. Not there yet. Yeah.
No.
Okay. Awesome. That's super helpful. Yeah, I've got to revisit that. And with what you gave me, we'll maybe go back through that, and maybe I'll reach out to see if you can answer some of those questions. Thank you.
What other questions or thoughts do folks have? So, Summer, are there often ways that you see people maybe misusing the tools, or sort of common pitfalls or things to avoid?
So I have deleted I have avoided giving the scoring to parents. I've had people come in and say, look, they scored exactly this many on this questionnaire, they have this. And I'm like, well, that's probably, so that part, it gets a little tricky. That's one pitfall. I mean, and then the main pitfall, I guess, being when they score positive for some things, I don't have anywhere to send them for help for a while. So that would be the downside. Whenever you give a screening, we all know whenever you give a screening questionnaire, you want your intervention plan. That's especially true of the trauma screens, even as part of like the our big increasing awareness in trauma-informed care and screening everyone for trauma is being able to then do something about it afterwards. And that becomes pretty labor intensive too. So.
Rachel and Jeremy, I'm wondering what your thoughts are for all the behavioral health folks in the room. Is there something that you see that works especially well when you're coordinating care? Do you want to see that screener? Are you hearing about language that screener was presented and are patients confused? Do you have any insights?
I like to see the screeners. I find the information useful, but I always have to remind myself that the screen is not a replacement for clinical judgment. The screen is not a diagnostic tool in and of itself. The screener is just a way to gather information in kind of an organized way. So like the GAD-7 is a great example, or the PCL5 for trauma. There's a lot of ways a person could look hot for a diagnosis on just using those screeners, like sleep is an example. A lot of those things we'll talk about sleep impairment. And so you look at, if you just looked at the screener, you would say, oh my goodness, this person's really dysregulated or having all these problems. There's a lot of ways to come by difficulty with sleep. It doesn't necessarily point to a diagnosis. So it's important to remember to use them responsibly. And I think Dr. Day did an awesome job kind of laying that out.
Yeah, and especially when you have I always hesitate when I have a screener that's only parents filling out, and especially in like older teens and adolescents, they don't have a child version because a lot of times there's disorders or problems being ascribed to children and young people that aren't necessarily there. So it requires a lot of follow-up.
Yeah, I think the coordination of care, like we've talked about before, is such an important thing with all of this, because, you know, with the pediatricians being able to see these kiddos relatively often, you know, at these regular intervals, I think, you know, you really get this opportunity to see the parents, to see the kids, and to ask these questions and use those initial screeners. And again, those initial screeners are kind of the gateway to, you know, referring to psychiatry or referring to psychology, either for a further evaluation or for treatment in that respect. So it's really, really helpful, you know, to have all of the medical professionals too, kind of looking out for these things and then, you know, sending them on for further evaluation.
Awesome, thanks for that. Michelle, do you have any insight or perspective in working in a psychiatry setting that would be helpful for the group?
Yeah, you know, I was thinking I do a little bit of work on an adolescent inpatient unit, and having those screeners available from the patient's primary care providers in an inpatient unit would be extremely helpful. Mostly because sometimes these kids aren't really honest with your inpatient physicians. They want to get out, they have that secondary gain. And it would be just really nice to know kind of what's going on at home. You guys are seeing them more often. what are some things we need to focus on an inpatient setting? I think they're great. I think, again, with Rachel, just that kind of collaboration between the inpatient providers and the outpatient providers, just get these kids a lot more help.